Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everyone. Today, I will discuss with you one common clinical case in the chest examination in PACES exam. Is it a bronchiectasis? Actually, in PACES exam, you can see patient with only bronchiectasis, or sometimes you can see patient with bronchiectasis and lobectomy, and sometimes you can see patient with COPD with the findings of a bronchiectasis. As we know that COPD, 30% of patient with COPD can has also bronchiectasis. So these are the scenario that can be seen in the examination related to bronchiectasis. First of all, when you go inside the examination room, first of all, grade the examiners. Don't forget this issue. After you clean or after you wash your hands with alcohol rub, so grade the examiner. And then go to the patient. Also grade the patient and tell him simply that I am Dr. Hassan, I want to examine you. If you feel any pain or discomfort, please tell me. So this is very important. Will not take more time, only 5 seconds to 10 seconds, this is thing. So I am Dr. Hassan. This is what's called patient's welfare, and there's also, as we know, marks for this issue. So I am Dr. Hassan. I want to examine your chest. If you feel any pain or discomfort, please tell me to stop. And then you can go to the read the sheet above the patient, because this is later on the examiner will ask you. I will give example. If it's written on this sheet that this patient has fever, then the examiner will tell you, what do you suspect the cause of fever in this patient? So this is very important to read what's written in this order. Will written sometimes shortness of breath, sometimes will written fever, or sometimes will written recurrent chest infection, like this. After that, go to the end of the bed and stand. Look for any clues, like sometimes you can see inhalers, sometimes you can see the patient taking oxygen, sometimes you can see the sputum pot. If you see it, go and see inside. Sometimes you can see the sputum, see what's color, see what's consistency. So very important. So look for any clues beside the patient, and then here ask the patient to cough and see if the patient has productive cough or dry cough, and this will give you important clues about your case. So here, if we suppose the patient has productive cough, so you know now, you put in your mind that this patient may has bronchiectasis, may has chest infection, may has malignancy. If the patient has dry cough, so put your mind that most likely this is lung fibrosis. So this is very important to start. And then count the breathing rate. After that, go to the patient. Here, start to examine the hands. And you should know what you would examine in the hands. You should know before to examine the hand what you should see in the hands. So here in chest examination, you should concentrate on 3 points only in the hands: presence of a clubbing, presence of cyanosis, presence of nicotine staining. These are the 3 points you should look for it in chest examination for all patients in chest station: clubbing, cyanosis, and nicotine staining. After that, check the pulse. While you are examining, in the same time, check the pulse of the patient. Then you should examine if the patient has flapping tremor that can be seen in hypercapnic encephalopathy, and this is important as a part of chest examination. So examine the tremor. After that, go to the eyes, examine if the patient has any evidence of anemia. And here you should also see if the patient has any evidence of cachexia, because as we know, many disease of chest disease can cause cachexia, like lung malignancy, like COPD, sometimes advanced lung fibrosis. So you should also see it and comment it. Then you should go to the neck. And it's very important to examine the neck as a part of chest examination. Very important. When you go to the neck, first of all, you should examine the trachea, whether it's deviated or no. As we know that the patient with lobotomy has trachea deviation. All patients with upper lobectomy will have deviation of the trachea to the side of lobectomy. While in patient has lower lobectomy, they may have trachea deviation, or the trachea may be not deviated. So the patient with upper lobectomy, it's necessary to have trachea deviation, while in patient with lower lobectomy, it's not necessary to see trachea deviation. So examine the trachea, whether it's deviated or not deviated. And then you should examine the cricoid notch distance. As we know that bronchiectasis also can be seen in patients with COPD. So you should examine the cricoid notch distance if it's reduced or no, because it will be reduced in the patient with a bronchiectasis, and also with patient with COPD, and see if there is any tracheal tug. This can be seen also in patient with COPD. And also you should examine here the venous pressure. You see, at least look to venous pressure to see if it's elevated or not elevated. The last part on examine the neck, you should also examine the lymph node. See if the patient has any lymphadenopathy or no. Then we should go to examine the chest. Always I advise and I prefer to examine the chest, to start examine the chest from back, because most clues will be in the back. So this is my advice. Start to examine the patient from back, then you can go to the front. The first step when you examine the patient is inspection. Many candidates forget to inspect the patient, especially if the patient has scars on the left side. So sometimes the candidate will not see these scars. So it's very important to take time to look for the scars. So here our patient, as we mentioned, you see this patient has first clubbing in his hands, as you see in this picture. Then when you go to inspect his chest, you will see the patient has thoracotomy scar. Sometimes the thoracotomy scar not necessary to be large like this scar. Sometimes only can be small and only on this area, as I use the pointer now. Okay, so especially if it was on the left side, so if you don't look for it, so you will not find it. Really, you should bend your head and neck to see the scar on the left side of the chest. It's not necessary to be seen here. Sometimes only can be in this area. So first of all, you should go to see the scar of lobectomy scar. Usually the patient with lobectomy, the ribs will pull it in the chest. So also below the scar, you will see that the ribs will be pulled in. So also you should see it and comment it. So now look for any scar, look for anything you can see in the chest, okay? and then you can go to the next step, chest expansion. Chest expansion usually will not change in the patient with a bronchiectasis. Chest expansion will be normal in patient with bronchiectasis alone. If the patient has COPD with bronchiectasis, so as we know that chest expansion will be reduced horizontally, but will be mainly vertical. The chest expansion in COPD patient will be mainly vertical and will be reduced in horizontal space. Patient with Lobotomy, as we know, the patient with Lobotomy, chest expansion will reduce it in the area of Lobotomy. Chest expansion will be reduced in the area of Lobotomy. So this is chest expansion. Then we can go to the percussion. Percussion usually in the area of bronchiectasis will be resonant. So the area of bronchiectasis will be, percussion note will be resonant. While in patient with COPD will be hyperresonant through both lung fields. Patient with Lobotomy, the percussion note will be dullness, will be dull in the area of Lobotomy. So this is what about percussion note. Then we'll go to the auscultation. Auscultation here, very important also. In the area of Lobotomy, we'll see that the breath sounds will be reduced. So in the area of Lobotomy, so the breath sound will be reduced. While in the patient in the area of bronchiectasis, will see or will hear coarse inspiratory crepitation. Coarse inspiratory crepitation. And this is crepitation will change with coughing. It's very important. Coarse inspiratory crepitation will change with coughing. This is crepitation sometimes hearing at late inspiration, or sometimes can be spanned through inspiration, or sometimes can be present during both inspiration and expiration. So the crackles or the crepitation can be sometimes during late inspiration, sometimes can be spanned through inspiration, and sometimes can be present during both inspiration and expiration. Bronchiectasis usually or commonly a focal process is involving loop, segment or subsegment of the lung, and therefore the crackles are often localized to this area. So usually bronchiectasis usually localized, and the most common sites for localized disease are left lower lobe and lingula. However, it may be diffuse process. It may be diffuse process, and the crackles can be diffuse, but usually, most commonly, it's localized. Then, usually, patient with bronchiectasis, about half of patient, you will see also you will auscultate scattered wheeze. Scattered wheeze presents in up to half of patient, and this is usually due to airway obstruction from secretions. Okay, so this is very important for patient with bronchiectasis. So, as we mentioned now, for auscultation for patient with Lobotomy, you will see decreased breath sounds in the area of Lobotomy. In patient with bronchiectasis, we'll see coarse crepitations and scattered wheeze. Then you finish examination from back. Now you are going to examine the patient from front. First step here to examine the second heart sound, and apex beat. Before to do these steps of chest expansion from front, examine any signs of pulmonary hypertension. This is very important to see if the patient has loud second heart sound, if he has palpable second heart sound, if he has left parasternal heave, if he has any sign of tricuspid regurgitation. Very important, because if you forget to examine it and elicit it, so this will decrease your marks. So this is first step when you go to the front. Examine for any signs of pulmonary hypertension and examine the apex beat. Why it's important to examine apex beat? For two purposes. First one, this patient has lobectomy. So usually the apex beat in patient with lobectomy will displace it to the side of lobectomy. If we suppose that patient has right lobectomy, so the apex beat will displace it to the right. If the patient has left lobectomy, so the apex beat will displace it to the left. This is first goal. Second goal, why you should examine the apex beat? Because as we know, important cause of bronchiectasis is Cardiac syndrome, and this is very common in examination. Many times, every diet, any centers can has case of Cardiac syndrome. And when you examine the apex beat, you will see that apex beat not palpable. Go to the other side, you will see, you will palpate it. So maybe the case of Cardiac syndrome. Please don't forget. After you finish examining the sign, you see, look for signs of pulmonary hypertension and apex beat. Now you can do chest examination from front, also inspection, chest expansion, percussion, and auscultation. All this step you should do it from front. Last step, here you should see if the patient has any leg edema. Say the patient has any peripheral edema. Now you finish examination. Now go to the examiner and start to present case. Actually, I advise you first to mention only positive findings. Only mention what you see in this patient. When you finish, you can present some negative signs that important. Or sometimes, because I know some candidate start to mention positive and negative signs together, and really will take time, and the examiner will stop you. Stop, no need to continue. So here maybe you will not mention all positive findings. So I advise you really to first present the positive findings. First of all, comment if the patient is breathless or not breathless at rest. So first comment, the patient is breathless or is not breathless. And here, most likely the patient has a productive cough, so you should mention. So the patient is breathless or not breathless at rest and has productive cough. The fingers are clubbed. Here also you should comment about any evidence of nicotine stain. Sometimes in patients with bronchiectasis, you can hear inspiratory clicks with unaided ear. When you are bedside, you can sometimes hear inspiratory click, and this is good indicator or strong indicator that this patient has bronchiectasis. So the patient is breathless or not breathless at rest, has productive cough, the fingers are clubbed. Here you should mention to trachea. The trachea deviated to the side of lobectomy or not deviated. Okay, and then you can mention for cricoid notch distance is reduced, especially if the patient has COPD, or not reduced. Then go to the chest expansion. Chest expansion, as we mentioned, reduced in the area of lobectomy. The percussion note in the area of lobectomy will be dullness. And in auscultation, there's the reduced breath sounds in the area of lobectomy. Why? The percussion note in the area of bronchiectasis is resonant. On auscultation, there are coarse inspiratory crepitation. You can mention where and how long extend. So where do you notice it? Yes, I heard, as example, coarse inspiratory crepitation at the right pace. And extend. Where is extend? And these crackles, it change with coughing. So you should mention it, that you should ask patient and see if there's any change. Also, vocal resonance will be normal in the patient with a bronchiectasis. And you should comment if there is wheezing or no wheezing. Then you can mention negative signs that the patient has no cyanosis, the patient venous pressure is elevated, has no signs of pulmonary hypertension, has no lymphoadenopathy. You can mention this is negative signs if not present because it's important. So you can mention it later. Then you can tell the examiner, this patient has a bronchiectasis with lobectomy, and mention which lobectomy. It's in the right or left, upper or lower, or middle or lingular. You should mention which lobectomy. Usually you cannot identify exactly for middle lobe or lingular, so you can mention that this patient has either left lower lobectomy or right lower lobectomy, upper lobectomy, right upper lobectomy, or left upper lobectomy. So now your diagnosis, this patient has bronchiectasis with lobectomy. Usually surgical resection can be indicate for localized bronchiectasis that poorly controlled with antibiotics. Sometimes in the examination you will see that lobectomy and bronchiectasis signs on the same side. As we mentioned that bronchiectasis in most patients will be localized, but sometimes can be diffused. So, but in the examination, sometimes you will see the lobectomy and the bronchiectasis signs on the same side. Sometimes you will see lobectomy in one side and signs of bronchiectasis on the other side. And sometimes if bronchiectasis is diffused, you will see signs of bronchiectasis in both sides and also lobectomy in one side. So this is what can be seen in examination. Now I will auscultate the sounds. This is the clapping. This is lobectomy scar. Now this is the sound. This is the sound of a crackles. I will repeat it. So this is the crackle sound. This, as we see, late inspiratory coarse crepitation. And sometimes, as we mentioned, can see or can auscultate wheezing like this. Okay, so this is everything about bronchiectasis and lobectomy. Sometimes the questions can be asked by the examiner. First question, what are the causes of bronchiectasis? The most common cause of bronchiectasis is infection, either childhood infection, respiratory childhood infection, like pertussis, measles, or sometimes tuberculosis. As we know, tuberculosis usually will affect the upper lobes. The other cause can be bronchial obstruction, either with foreign body or endobronchial tumor, or sometimes by lymph node as in tuberculosis, sarcoidosis, and malignancy, and also sometimes granulomata as in tuberculosis and sarcoidosis. The other cause is mucociliary clearance defect, cystic fibrosis, and Cartigener's syndrome. Third cause is immunodeficiency, either congenital and acquired hypogammaglobulinemia or acquired immunodeficiency syndrome, HIV. And sometimes bronchiectasis can be seen in rheumatoid arthritis or Sjogren syndrome, but here you should look for other clues for rheumatoid arthritis, and can be also idiopathic. So the causes: infection, bronchial obstruction, mucociliary clearance defect as cystic fibrosis and Cartigener syndrome, and can be idiopathic. The second common cause: what are complications of bronchiectasis? Pneumonia, empyema, collapse, respiratory failure, and pulmonary hypertension. Now, how can confirm diagnosis of bronchiectasis? The gold standard investigation for diagnosis is high resolution CT. High resolution CT. Here you can see signet ring sign. Signet ring sign. This means that bronchial diameter greater than the adjacent vessel diameter. You should know this. Maybe the examiner tell you what this is signet sign, signet ring sign. So you should answer this question. What the findings on spirometry? Usually spirometry, most patients with bronchiectasis pulmonary function test may be normal, but most common abnormality is obstructive pattern. So most patient the pulmonary function will be normal, and the most common abnormality is obstructive pattern. What are the most common respiratory pathogens in patients with bronchiectasis? Usually Staphylococcus aureus, Haemophilus influenza, Pseudomonas aeruginosa, and sometimes Klebsiella also. How can manage this patient with the bronchiectasis? As we know here, you should tell the examiner, we need patient education, we need counseling, we need multidisciplinary team. If the patient is smoking, he should stop smoke. He needs immunization for influenza and pneumococcal pneumonia. Maybe the patient in advanced case need long-term oxygen therapy. Then the patient need postural drainage and physiotherapy. Postural drainage with percussion and vibration. The patient need antibiotics. The patient need bronchodilator therapy, anti-inflammatory medication like inhaled or oral corticosteroids, and as we mentioned, surgical resection for localized bronchiectasis can be indicated, especially if the patient has poorly controlled symptoms. This is the question you can suspect in the examination. So as we mentioned, and this is very important, bronchiectasis is common case in PACES exam, can come alone with no other findings, and sometimes can come in the patient with COPD, and sometimes can be see patient has signs of bronchiectasis with lobectomy. Thank you very much for your listening, and next time we'll present also other interesting case in clinical examination. Thank you very much.